CR what?
AT.
Okay, so what's that stand for? Okay, what's the ACTH work on? Adrenal. Cortex. Okay, and is there a negative feedback here?
Yes.
No, there is no. Okay, all right. So keep those in mind. So we're going to start off with Cushing's. I can tell you in all my endo years of working, I've seen 10. And so those were medically managed. The surgical people I never saw. So not very common even with endos. Most of the time, Cushing's is due to what?
Increased cortisol.
Say it again. Overuse. You mean like taking steroids?
Increased cortisol.
So, is it here? Is it here? Is it here? Where's most of it coming from?
Adrenal.
Here. Okay, most of it's here. 80% of it's there. So most of the time it's going to be surgical. So what we're talking about today is the medical management, which is a small percent of people. Okay, 20% is ectopic. What does that mean? It's coming from tissue other than what's usually designated to do that job. Okay, so it can be an ACTH producing tumor. Where would they most likely be? And you have other endocrine tissues, but in this case, the lung, if you ever have to just guess an ectopic secretion or tumor, I always think lung. It tends to do a lot of different. SIADH, ectopic producing tumor, lung. Okay, so about half of them are in lung, pancreas, thyroid, could be others. Okay. All right, so let's look over on page 2. Okay, so hypercortisolism. So cortisol, think cortisol steroids. Okay. So we tend to use lots of different words. It's like when I lived in Kansas City. Okay. I lived on a street. I worked in Independence, Missouri, but then I would go home to downtown. No, I didn't live in downtown. I lived south of downtown by the by the plaza in the art district. So I would get on the road from the interstate, and I never got off the road, but it changed names 3 times. When I first moved there, it was terrible. I got lost so many times. So what my roommate did is she took me to the TV tower, and she said, okay, from the TV tower, if you ever get lost, go to the TV tower, and here, take this road, and it went right to our house. So that helped me several times. Then I learned all the names of the street. Okay. So same thing with cortisol, steroids, corticosteroids, glucocorticoids. They're all the same. So most of the time we're going to treat it surgically. So we're going to take out a tumor in the pituitary. So what do we call that kind of surgery? Transsphenoid. Okay. So we take it out, and they're good. Ectopic, we remove the non-pituitary tumor, or we may have an adrenal adenoma. Carcinomas are really rare. Dr. Brand told you that. Cancers of the endocrine glands, unusual. Mostly they're adenomas. Doesn't mean they're not troublesome, but they're still not usually cancer. Okay, so medical therapy. So we use medical therapy when we can't surgerize them. They refuse surgery. We have to delay surgery. So we have 4 drugs types that we can use. We can interfere with enzyme systems that produce cortisol. We can use adrenolinic agents that just kill the adrenal cells. Or we can target the pituitary. We don't do that very often. Or we have receptor antagonists. So we have lots of different ways that we can interfere with these production. Okay. So the medical treatments are listed there. The goal of treatment is we want to normalize, so we want to get cortisol levels back to normal. Because if we have too much, what kinds of things happen? Too much steroid does what?
Increases blood sugar.
Increases, so hyperglycemia, new onset diabetes, what else?
Immune suppression.
Okay, one person say one thing.
Go, Taylor.
Immune suppression.
Immune suppression, okay, I'll go. Okay, did you have another one? Osteoporosis, second row, want to add to it? Looks smart.
Cataracts?
Cataracts, Olivia's row, high blood pressure, Bailey's row. Getting down there now. Okay, if you get osteoporosis, what are you going to be at risk for? Fractures. Dim, your row? Bruising is common. Changes in skin, stria. Okay. All right. So 2 approaches. We can block and replace. So we can totally ablate the ability of the adrenal cortex to produce cortisol. And then we just replace them. So then we did that with the thyroid. We knocked it out and then we gave it back. Okay, so similar type of approach. So people have wide variability. Their serum cortisols are all over the place. Their urinary excretion of cortisol all over the place. So you've got to do multiple tests to figure out their variability. So that works well there. If not, you can go with just reducing cortisol levels to normal, so normalization. People that stay in a fairly tight range, then they're easier to handle that way. Some of the things to think about outside of that. It really is a devastating disease. It gets very difficult to control. So educating people, the people they live with, the people themselves about the disease, what they're at risk for. Monitoring for cortisol-dependent comorbidities. So you mentioned a lot of these. Another one is the psychic effects. So steroids, some of the reasons people like to take them is because it just keeps them euphoric all the time. Or they get very depressed, or they get psychotic. So you can see all the range of different psychic disturbances with steroids. You mentioned the other ones, diabetes, hypertension, hypokalemia. Why does that happen?
Cortisol raises blood sugar.
Pardon?
Cortisol raises the blood sugar, so it's hyper.
Say it again.
Cortisol raises the blood sugar, which leads to hyperglycemia, which is diabetes.
Right. So high insulin levels. So one of the reasons we use to treat hyperkalemia is we use insulin to drive potassium in. So some of that happens. Some of it's renal effects as well. Evaluating them for risk. The risk factors for, what is VTE? Well, if Monday was long ago, then cardiology was in the ice age. Okay, so think back to anticoagulants, VTE, venous thromboembolism. Okay. All right, so what are the risk factors for VTE? Okay, so tell me more about that. Practical, put it in practical terms. Okay, hypercoagulability, what 2 states would that be? Well, okay, yes. What changes in the coagulation flow or cascade can put you at a higher risk of
What's the question?
protein C, protein S deficiencies? Okay. Factor 5, Leiden. Those are common. What else? What else puts you at risk?
Hypokalemia.
Say it again.
Hypokalemia.
Hypokalemia?
Potassium.
With clot risk? Could be. Not that I know of. Not that I know, but that could be. What else? If I put you in bed for the next month, is your clot risk going to go up? Yes. So what immobilizes people?
Surgery.
Surgery. Okay. Putting them in a cast that they can't move a limb will do that. So any type of immobilization will do that. What else?
Any type of cancer.
Cancers will do it. Cancer increases, makes you more hypercoagulable. Trauma, if I put you in a car wreck, that will do it. So think back to those things when you see this. Okay, so that means you need to assess their risk, and if they need to be put on an anticoagulant, that needs to be done. 10 times the risk is quite high. So if they have a family history, usually protein C, protein S, factor V Leiden, all of them will have family history. They'll tell you, my mother had their first clot at 35. My sister has already had a clot. Well, we haven't gotten there yet. Estrogen use increases the production of vitamin K dependent clotting factors, which are what? Yes, 2, 7, 9, 10. 2 plus 7 is 9 and 1 more is 10. All right, very good. All right, page 3. Here are all the flow. You see it in picture, and I've written it out too. The end game is we produce cortisol, aldosterone, and testosterone or androgens. And where does it all start? Cholesterol, that bad entity. That's what irritates me so much, is we demonize something that's extremely vital. That cholesterol moiety is used by the body to make all kinds of things. It also helps your cells stay in place so that you're not a puddle every day you walk in. We have to just run you in and reform you. So cholesterol is important. Okay, so the adrenal cortex has 3 layers. What are they? And what did I teach you? Salt, sugar, and sex. Okay, it works, doesn't it? So salt are the mineralocorticoids. What is the major production there? Aldosterone. Fasciculata is what? Sugar, so the main outcome there is cortisol. And for the reticularis, it's the androgens, DHEA would be another. Okay, so if we can disrupt these pathways, then we can get rid of some things. So if we could target an enzyme that makes a certain thing, then we could block the production of cortisol or aldosterone, testosterone. The only thing is that they're very intertwined. If you look in that picture at the bottom, you start to see that the precursor of one thing is also available to another layer and produces something else. So we'll see that sometimes when we knock out one layer, we just force all the raw material into the other layers, and so they'll make more of it. Just like the thyroid, when we gave it more iodine, what did it make? It made more T3 and T4. So sometimes when you give the liver more saturated fats, it makes more LDL. Okay? Not all the time, but sometimes raw material excess will result in excess of a product. Okay, next page, page 4. Okay, so those 4 categories, 3 of them work on the adrenals, 1 is pituitary. So somatostatin analogs work on the pituitary. Do you remember anything I told you about somatostatin early on? Where does it come from? Delta cells. And what did I tell you about somatostatin? The only thing?
Inhibitory.
It inhibits everything. If you remember that, it's a good place to start. And we'll see that again and again. It likes to inhibit the effects of other hormones. Okay. So we've got steroidogenesis inhibitors, those are the adrenal enzyme inhibitors, the adrenalytics again, the glucocorticoid receptor antagonist, and the somatostatin analogs. The steroidogenesis are probably the biggest group. Metarapone, ketoconazole, etomidate are in that group. If you look at the page before, you'll see where you'll see some of the places where they're keyed that they show up. So I showed you where ketoconazole, it's very powerful and has been considered first line for a long time. What do you remember about ketoconazole? We have talked about it before. hepatotoxicity, it tells you, its name tells you what it is. It's an azole. So what do we use azoles for? Antifungals. Okay. In this case, they're very good, ketoconazole in particular, at inhibiting some of the enzymes in the adrenal gland that lead to the production of cortisol and androgens. All right. And it can be hepatotoxic. So you'll see the term medical adrenalectomy. What does that mean?
Surgical excision.
Okay, so instead of surgically removing a gland, we inactivate it or make it not operable by using medications to do that, or chemicals. So these drugs tend to be the best with AC-dependent Cushing's syndrome. So, right, for this type of Cushing's that's produced by the pituitary, it's pretty good. Okay, so ketoconazole, agent of choice. We use high doses. We start off with about 200, 2 to 3 times a day, and we up it as fast as the patient can tolerate it up to 1,200 milligrams a day. So it has to be given in multiple times a day for it to be effective and tolerated. So it decreases cortisol production. That's the thing to remember. That's why it makes sense in Cushing's. You can measure its effectiveness within 1 to 2 days. So you can look at serum cortisol, you can look at urinary excretion of cortisol as your ways to monitor its effects. So you can see on those high doses, you start to get other endocrine effects. So complaints that people may have, you mess with women's periods. Irregularity may be a problem. Irregular cycles. Decreased libido. You can see why, because you decrease androgen production. Gynecomastia. So you might be interfering with estrogen levels. What also is going on in the pituitary with prolactin, and you get elevated liver function tests. That's a big one to remember because it can be very hepatotoxic. Also the azoles, one other thing I told you is they interfere with everything because they're 3A4, they work through 3A4. So since most of our drugs are metabolized through that pathway, always big interactions. If you've got somebody on an azole and you're going to add to that regimen, you've got to look up the drug interaction. They're inducers, inhibitors, they're one of the big league when it comes to drug interactions. So getting baseline, following it periodically to make sure that the person's tolerating it. If they already have liver disease to begin with, they are not going to tolerate it because the doses we use are just too high. You don't want to use it with other drugs that are metabolized, like the statins. So I drew this for you before, but what it does is it increases area under the curve. So if you take a drug and we're saying this is the effective part, what this drug does is it interferes with metabolism, so what you get is this, instead of it being this, you get this kind of stuff. You can't get rid of it as fast. So then you get huge, big changes in area under the curve. It stays around longer, exerts more of an effect, people get sick. So big interferes with metabolism of other drugs. Ketoconazole is different in this group of azoles. It requires an acidic environment to get absorbed. So don't use it with drugs that change the acid environment of the stomach, which would be what? What 3 do we have? PPIs,
H2.
H2 receptor antagonist, and good old, oh come on, antacids. So Tums, Linlanta. Okay. All right. So don't take them with those. It prolongs QT interval. You just can't escape it. Okay, what drugs? Give me categories of drugs. Give me categories. Okay, quinolones.
Is that the same thing as macrolides or macrolides?
Yes, amiodarone a little bit. So you've got
Right.
antiarrhythmics.
I think it's macrolides.
You got that's, so amiodarone is which class of antiarrhythmic?
Class
3. The others that prolong are the ones like quinidine. Quinolones, what other antibiotics? Macrolides. Okay, what other group of drugs?
Beta blockers.
I don't think beta blockers. Beta blockers do AV or AV node conduction. So they slow it, they are PR interval extenders.
Oh, didn't we have an SSRI or one of those that?
Did. Citalopram, right? So we even limit its amount. What other set of drugs did I give you a massive table on in terms of all of the side effects that are in the monitoring?
Seizure meds or anticonvulsants?
Anticonvulsants, I'm sorry, the antipsychotics. The atypicals. Okay, so there's a big list, so think about this. Know those QT prolongation drugs, especially if you got a cardiac patient that rolls in. Okay. Zofran, you mentioned, okay, you got most of them. All right. Page 5. The tyrosine. Okay, so this one blocks the final step in cortisol synthesis. So if you look back at that page, I put a little block box there that shows you what it does. Okay. Now, it increases androgen production. So look at that picture and look at how that might happen. Because you see that throughout, you've got different precursors that are throughout those layers. So here's an example of you knock out one layer and you knock out that enzyme system, then you may be shunting products or things that the other layers can make into something else. So what do? They make more androgens. Do women typically like to have a lot of androgens circulating? No. Okay. So if they start growing beards and their voice drops, they may get upset with you. So we don't want to use it as first line in women who have to use it a long time. Short time would not be so much of a problem. Salt and hypertension, why is that? How can that be? Okay, because you're increasing aldosterone production. Okay, remember where does aldosterone work? Works on the kidney in the collecting ducts to reabsorb what? Sodium and water. Okay, and it's under the direction of what? What stimulates the aldosterone production? Angiotensin II. It's terrible when you have to learn when you have to remember all this stuff. You know, I realized that it really came home to me when I had a child in lower school, that when we get to middle school, we get very siloed. The teachers become very focused on, they go to school, they're a social studies teacher, they're a math teacher, so that's what they teach to their strengths. In lower school, they don't do that. Everybody has to teach to everything. Because, you know, I never had Cameron come home from 4th grade and say, can you believe it? They want us to remember what we learned in 3rd grade. They expect me to know where a period goes. That was 3rd grade. This is 4th grade. See, we lose that at some point because we start siloing all of our stuff. But now is the time. We got to bring it back. I told you endocrine was one of the big ones that will just forces you to bring stuff back together if you want to understand it. And you can. You just have to run your brain over those grooves again and it'll go, she wants me to know this. And they want me to know this. and you'll remember. Okay, adrenal-lytic agent. So mitotane is one of the adrenal-lytics. There's only one in this category. They're very powerful. They destroy the cells, so you can't produce it anymore. So they destroy it in the zona fasciculata. So which one is that? Produces what? Cortisol. Okay, so that's doing like what we want. And the reticularis. So then what happens? Androgen. So what would you expect they're going to complain about with this drug? Low androgen levels. So decreased libido. So all the things that would go along with the low androgen would fall with this drug. So this drug is a true medical adrenalectomy because it's going to take out those layers. You won't see it as much. It's very powerful, but because of the problems, it doesn't tend to be used first line. Lots of drug interactions, so I'm just putting it in your brain, look it up. If you're adding to, most of the time, unless you're working at endo, you're not going to be, you won't see these drugs, you'll see the people coming to you for other reasons. Adverse effects, you can see that it's a hard drug to tolerate. I mean, when you get up to 30%, that's a lot. I think of anything 5% or above is worth my attention. So this is 30% nausea and vomiting. The other thing, and this goes for any time you are going to decrease the ability of a person to produce endogenous steroids or endogenous cortisol, that in an emergency, that is one of the things you call on. So you need cortisol in emergency. You're in a wreck, you're in a big infection, anything that's a huge stress. If you can't produce cortisol, it will kill you. So people who are on that drug and are undergoing a major shock, they have got to have steroid replacement. Let's see. Two things at the bottom. If they're on anticoagulants, and we talked about them being at higher risk for VTEs, then they might be on an anticoagulant. This drug, mitotane, will increase their bleeding risk. The other is that it's a teratogen, so warning women about effective contraception would be important too. Questions about those two to this point? Are you following? Things are coming back? That's good. Okay, page 6. So glucocorticoid receptor antagonist. So look back at that picture again. This drug hits progesterone. Right up here. Very early in the process of everything. And you'll see that progesterone serves as a substrate for other production of other things like cortisol and the androgens. So the earlier you are upstream in anything, usually the more side effects and the problematic. It's like you poison the stream in the mountains, everything down below it then gets sick. Okay. So Corlin or mifepristone is an anti-progestational drug. It really came to notoriety, I don't know, 25 years ago. RU480. It is an abortifacient, so if this is the only oral abortifacient that I'm aware of. So women could take it up until 12 weeks and induce an abortion. So progesterone is produced early on in the women's cycle by what? What structure gives rise? So the luteal phase is the phase where progesterone is produced. What sustains that phase of the menstrual cycle?
Is it the corpus luteum?
Corpus luteum. So the corpus luteum secretes progesterone for about 12 weeks until your placenta can pick up with enough production and maintain a pregnancy. So women who can't maintain, their corpus luteum doesn't maintain or they can't put out enough progesterone, usually will always have miscarriages before 12 weeks. So that's where this drug originally came out, was against with that in mind. So you see that big black warning, box warning, is that abortifacient activity you need to keep in mind. So women need to know if they're going to take it, that's a problem. Especially if they're considering or entertaining a pregnancy, or before you use it, you want to make sure you have ruled out pregnancy prior to starting it. So the indication for this drug is fairly narrow. So if you look under indication, it controls hyperglycemia secondary to hypercortisolism. So it's recommended for those with endogenous, so not induced by taking of steroids, in those who have type 2 or glucose intolerance and have failed surgery. So you can't go back and redo what has been done, and their sugars are really high. Because you go back and look again at that thing, how is aldosterone levels going to be affected? You see, on the march to aldosteronism, progesterone is early on. So what's aldosterone do? Sodium, but we always maintain that neutrality. So if we reabsorb sodium, what do we excrete? Potassium. So these folks can get hypokalemic, so you have to give potassium supplements. Okay, drug interaction, lots of them. So look, this is another one of those look up. Adverse effects, so look at fatigue, nausea, headache. People really have to want to treat something in order to tolerate. It's a lot. It will go away with time, but it really is hard, and the majority of people will get it. If you look at the next row, endometrial hypertrophy, why is that?
Progesterone.
What's the luteal phase of the, yes, progesterone. What's the luteal phase of the, due to the uterus? It's the increased glandular development, thickening, getting ready for a fertilized baby. Hypokalemia, arthralgias we talked about, and then the others, the vomiting, hypertension, dizziness, decreased appetite, you'll see with a lot of these drugs. Okay. Contraindications, pregnancy, because you won't be able to sustain it. Co-administration with those statins. Unexplained vaginal bleeding, so we want to rule that out before starting. And endometrial hyperplasia with atypia or endometrial carcinoma, because it will just make it worse. Okay, caution, so do not use so we're not going to use it for diabetes. You never saw it pop up for diabetes, right? So we're not going to use it to treat hyperglycemia for other reasons, just when you're under Cushing's disease. Next page is one of those QT interval prolongations, so keep that in mind. Everything else I think we have. Somatostatin. So this is what. So those three are all adrenal. This one is the pituitary. And again, we talked about somatostatin interfering with both. So it will inhibit ACTH. So it'll inhibit ACTH secretion from the pituitary. Again, it's going to be only when you cannot surgically remove the adenoma. Okay, because you're affecting pituitary function, then a lot of those things you see down there is effects that would be downstream. So blood sugars, liver, potassium, magnesium, TSH, growth hormone, so other anterior pituitary hormones may be affected as well. Adverse effects, mostly GI and liver. You're seeing endocrine effects there as well. So most of these people are going to have trouble with blood sugar regulation. very last, it's good to warn people that early on they can have an increase in blood sugar, and then you can see it in the first 2 weeks, and then it can go down. So you get a decrease in insulin secretion with this drug. So that's the problem, is that it's not the effects on so much sugar metabolism, it's on the insulin production by the beta cell itself. Next page, QT prolongation. So kind of wrap that around these type of medications. Supplement with potassium and magnesium. So most of these are going to affect potassium because they're going to affect aldosterone production. This next section is, I just wanted to show you what, an example. I'm not going to ask you to repeat any of this, but if you're going to remove an adrenal adenoma, what happens is if you remove it out of one side, then the other adrenal gland tends to be hypoactive. So you have to replace steroids for a while until the other gland can pick up. So this is steroid replacement. You see that it's quite a length of time, up to a year. Then you will titrate them off of it, following AM cortisol levels until that gland. The gland really it will recover, but it really does take a long time. If you have someone on steroids for a while, you can just double or triple the time that they were on those steroids to the time it will take the axis to recover. So you can see what they do is they're using IV until they can convert them over to PO, and then they're using, if you think of physiologic being about 5 milligrams a day, you can see that even out 3 weeks, they still have them on about 30. Eventually, we'll consolidate them to once a day if they can tolerate. Sometimes people can't tolerate a large dose of steroids, and so it helps from a GI standpoint. So dividing it up sometimes will help a lot. Okay, questions? Look at those big categories, because again, you will not see these drugs very often. If you do, you should always go back and review them, because they have lots of side effects, lots of untoward effects that may show up in your practice of your primary care, or if you're in the ER. I did see a person come in one time in the ER, and it was terrible because he was deaf. He just could not communicate what had happened to him. He had been on steroids, had come off of them. He had I don't remember exactly what, I think he was ill. I think he had the flu. And they thought that's what it was. They sent him home and he died. And it was because we did not understand that he needed that steroid replacement in whatever had set him up to be ill. Okay, all right, so let's take a break. We'll do 10 minutes and we'll come back and pick it up with primary hyperaldosteronism.
What time?